It's a pleasure to introduce our first speaker, Jennifer Beck from Toronto. What can we learn from the diaphragm electrical activity?
Good morning, everybody. Can you all hear me okay? It's a good sound. So I have the pleasure of presenting a topic which I think will be setting the stage for the rest of the next 2 days, because we're talking about personalizing mechanical ventilation, and the diaphragm electrical activity is really the patient's respiratory vital signs. So we'll learn a lot about their breathing and how they interact with ventilation. So I'll describe to you a little bit about what the diaphragm activity is. I do have to make a disclosure that I am a consultant to Beck Critical Care, and I receive payments because of royalties. And I think that we have to talk a little bit about the physiology of spontaneous breathing in order for everybody to be having the same knowledge for the talks that are upcoming. And I really wanted to clarify where the EDI, or the diaphragm electrical activity, comes from. So again, I'm going to show the same slide I show almost every time I give a talk on this topic. But during spontaneous breathing, the signal for breathing arises in the respiratory centers of the brainstem. And the signal travels down the two phrenic nerves. And this excites the muscle fibers of the diaphragm. It electrically activates the diaphragm muscle fibers. And the electrical activity spreads throughout the muscle, and this initiates muscle contraction, and that causes the chest wall and the lungs to expand, and you get airway pressure and flow. So really what we're looking at when we talk about diaphragm activation, EDI, diaphragm EMG, as you'll see in my next slide, is really electrical activity of a muscle. Just like the ECG of a heart or the EEG of a brain, we're not talking about the force, and we're talking about the spontaneous activity of that diaphragm activity. So again, just to clarify, when we started doing our research, we initially referred to this signal as the diaphragm EMG because we are recording an electromyogram signal. Later, in our research publications, we called it the EADI, the electrical activity of the diaphragm, or today on the commercial ventilator, it's known as the EDI. So it's all the same thing, EDI, EADI, EMG of the diaphragm. And when one of the basic structures of skeletal muscle, so the diaphragm, is something called a motor unit. It's where the nerve joins to the muscle and stimulates several muscle fibers. As you can see here, here's one motor unit. And if you were to slap electrodes on this muscle and stimulate it, you would see something that's known as a motor unit action potential. So that's a voltage difference between the electrodes. Now, when we breathe spontaneously, we're actually recruiting several motor units. We recruit them at different rates. So as the inspiration progresses, we increase more and more the motor unit recruitment, but also their firing rate. So if you have electrodes in the vicinity of this muscle, all the motor unit action potentials sum into something called an interference pattern signal. And this is an EMG signal, and this is what we're recording from the diaphragm during spontaneous breathing. So here is just to show you a visual. This is one of the arm muscles. Just put some electrodes here to show you that with intermittent contraction, the brain is sending signals to the arm, electrical signals. So these are the interference pattern that I was describing earlier. And through signal processing, you can actually get waveforms that you can analyze. So this is just to show you recent work by Dr. Seek that's done with implanted needle electrodes in the rat diaphragm. Just to show you again, here's your interference pattern signal. So this is during quiet breathing. So you have the noisy signal, which through processing can turn into a waveform that we can interpret. If they do hypoxia or hypercapnia, you can see that the bursts of the signals for each inspiration get larger, and the waveform also gets a little bit bigger. This is for a deep breath, etc. So you can see here that we are finally getting a signal, which is our EDI signal, that you can interpret in terms of its timing and its amplitude, etc. So how do we measure diaphragm activity in humans? I just showed you the implanted needle electrodes in rat diaphragms. Well, most of you already know that what we've done is we've taken advantage of already existing clinical treatment in patients. So what you have is your standard nasogastric feeding tube, I put a picture of a baby here, but this is for all ages. And you can also have it pass through the mouth if you're doing non-invasive ventilation. So it's a standard feeding tube that has all the feeding holes. But what we've done is we've placed miniaturized sensors on the feeding tube above the feeding holes in the area of the gastroesophageal junction, and that in that position we pick up spontaneous activity of the diaphragm. So again, it's feeding this way, and we have our electrodes here, and the signals go out through a different lumen and are picked up there. And you can see here on the right an example of the leads that we have. So these miniaturized sensors on this electrode are actually an array of electrodes, and that way we can always track where the diaphragm is during inspiration. And you can see here examples of the raw EMG that is picked up on these electrodes, but you can see here there's also the ECG that we have to take away. And you can see here is the processed waveform that we are looking at for monitoring and controlling the ventilator. So you can see here's an example of a neural inspiration, and here's an example of a neural exhalation. And this waveform can be quantified to give us its peak value, or at the end of exhalation you can look at its min value. And you can also look at neural respiratory rate, neural inspiratory time, etc., etc. But basically, the more you try to breathe in, the deeper your breath, the bigger the waveform. This is what the diaphragm activity looks like in infants and adults. So this is a 2-minute time tracing. Here you have the example of the adult, which you can see is actually, it's quite a stable breathing pattern. It's not as variable as the babies. But what's interesting is the difference here is the baseline. As you can see here, the adults breathe in, they breathe out, and then they go back to baseline. They breathe in, they breathe out, back to baseline. Whereas the babies have a tendency to not breathe out to baseline. As you can see here, the baseline activity is more elevated than here. So they have an elevated tonic activity of the diaphragm. They also do these large neural inspiratory efforts. We call them sighs. We actually have evidence in the CT scan in animals that this recruits the lung. So you can see here the differences between the infants and the adults. Another thing I wanted to point out is something which is we can also detect central apnea, and it's maybe a little bit more important, the central apnea of prematurity. And you can see here the examples. This is the ventilator pressure, this is flow, tidal volume, but I just wanted you to focus on the diaphragm activity. Again, we have a 2-minute period of diaphragm activity in a premature baby, and you can see that they take these pauses of 10 seconds or 5 seconds, and you have the variable breathing pattern and this huge increase in tonic activity, even though they're still breathing phasically. So there's a lot of information that you can gather from the EDI waveform. So let's talk a little bit about the responses to different interventions. This is a paper that came out, oh my God, almost 10 years ago now, by Guillaume Emeriot in Montreal. And so what we have here is the diaphragm electrical activity when the baby is on a PEEP of 5. I think the SIMV rate was so low here that this is almost, this is just the spontaneous breathing part. And then what happened was when we removed the PEEP, you can see here there was an immediate increase in this tonic activity of the diaphragm. Then when we put the PEEP back on, so we're back up here to 5 centimeters of water, we were able to bring it down again. And this is one of the responses that's going to be important for some of the lectures that you'll hear later today. And what we found is that what it is that the tonic activity is actually present because it's probably keeping the baby's lungs recruited. So it's like they're doing their own intrinsic PEEP. I think you've all seen this picture before, and I mentioned at the beginning that the breathing that we're talking about probably today is mostly going to be a lot about central responses. So you can see here that there's a lot of feedback going back to the brain, coming about the blood gases, about tension in the muscle or in the rib cage. There's a lot of reflexes coming from the lungs and the upper airways, and they all feed back to the brain. And I tried to simplify this picture into something that would be less with arrows and more conceptual. So I developed something that looks, now I'm being told it looks like a martini glass, but it's actually a funnel. But I really wanted to point out the 3 major factors that are at play inside the respiratory centers and how they all converge on the output to the diaphragm. So I color-coded lung stretch, muscle force, and the CO2 response into the phrenic nerves, and this is what controls our EDI signal. So these are the three main factors. Of course, we talked about the upper airways. There's a voluntary override and the impact of sedation as well, we'll hear about today. But it was just basically to try to simplify the concepts. Talking a little bit more about the EDI responses. So this is a group, this is Dr. Rafferty's group from England. And you can see here, I just wanted to show you that if you increase a load, your diaphragm activity will increase. I think we all know that by now. If you have to breathe against a load, let's say a high resistance, you're going to have to recruit more and more of your diaphragm motor units to be able to maintain your ventilation. Same thing for the CO2. Increasing the CO2 causes an increase in diaphragm activation. Talking about mechanical ventilation, this is a paper we did in 2001, and it shows the diaphragm electrical activity at different levels of pressure support. So at 0 level of pressure support, and this is the transdiaphragmatic pressure responses. You can see here with no help from the ventilator, there was a huge effort in terms of the EDI and the transdiaphragmatic pressure. This is an average breath taken from 5 minutes. And then as we added pressure support levels and increased it, we unloaded the diaphragm, but this was associated with a deactivation of the diaphragm. So we have a reduction in the respiratory drive, but as well unloading of the muscle force. So one of the problems with increasing pressure support that people have learned since the last meeting more and more is that as you increase the assist more and more, you actually have a tendency to over-assist. And there's several papers that have come out now showing that a lot of the time we think that the patient is triggering the ventilator. In fact, we're not. So this is a slide I took of a patient on pressure support. This is on the Servo-I ventilator. The yellow waveform is the ventilator pressure. It's in pressure support, it's an adult. This is flow, volume, and diaphragm activity. And I think if you did not have this waveform here, or it was actually on overlay here, but if you just had the yellow, green, and blue, you would think that everything was fine. But how would you know that this patient is not breathing at all and not using their diaphragm? And I asked Leo, can you send me some slides of patients who are not breathing on pressure support? He just whipped these off to me by the next day. So you can see here, again, patient, no diaphragm activity, no diaphragm activity. But the ventilator is triggering and everything is square wave and looks perfectly fine. So you can see here an example where actually they switched from the NAVA mode, which uses the diaphragm activity, and they switched over to PRVC. And you can see here immediately, in fact, this almost looks like a reflex silence of the diaphragm. So there is diaphragm activity. The patient can generate diaphragm activity, but the minute they switched over, the diaphragm activity went away, completely silenced. So it is a central apnea because there's no signal coming from the brain to the diaphragm. But if you didn't have the EDI in your face, let's say, you would never know that this patient is not breathing. This is a study we did in Montreal. It demanded a Q4 morphine for a patient. And you can see here, we were doing our NAVA trial. Everything was running smoothly. Out the nurse came. We have to give morphine. And right away, diaphragm activity went away. So the patient had to go into pressure control backup. So again, one of the things we can learn about EDI monitoring is not only are you over-assisting your patient, but are you over-sedating the patient? And I think this is a very useful tool for people who, like the nurses at the bedside who are giving the sedation, to be able to titrate the level of sedation they're giving so that, yes, you can give sedation, but maybe not so much, and you can follow the signal and make sure that the diaphragm is still being used. And this is one of the best quotes I've read in the last year. It's from Basil Petrov's group in Montreal, and it's a molecular biology paper on ventilator-induced diaphragm dysfunction, but I love the first sentence of his abstract. The diaphragm is a unique skeletal muscle designed to be rhythmically active throughout life, such that its sustained inactivation by the medical intervention of mechanical ventilation represents an unanticipated physiological state in evolutionary terms. The diaphragm is always supposed to be active. It's like the heart. You wouldn't stop the heart for any reason except, of course, for surgery. I mean, everybody in this room has diaphragm activity and everybody is breathing, and there's no reason to stop the breathing unless there is a reason to stop the breathing. However, if we can avoid the disuse, And we're going to hear a lot about that tomorrow morning, I believe. So Hans mentioned a lot about this diaphragm activity and patient-ventilator interaction. So another thing we can learn about the diaphragm activity is how dissynchronized patients are with the ventilator. It was previously unknown. This is from an adult patient. This is the ventilator pressure in yellow, and we took the diaphragm activity and overlaid it on top, so you get a real patient-ventilator interaction at the bedside. And where we've put the white arrows is where patients are making an effort and failed to trigger the ventilator. There's also other dysynchronies, trigger delays, or when the ventilator continues to give assist. However, it's extremely prevalent to have poor patient-ventilator interaction. This is an adult. Things get worse in the babies. This is a slide that I got from my friend Howard Stein, and it shows you again the patient-ventilator interaction, so patient in white, ventilator in yellow, and you can see here the wasted efforts again, and you see here the baby wanted more air, didn't get it. Here the ventilator triggered late, but then it kept going when the baby didn't want air. I mean, it's dysynchrony. Anyway, I guess we're going to see this slide a lot in the next 2 days, but just to show you that it is important, the asynchrony, because now there's more and more evidence that it affects your outcome. I won't get into the details of this study. One of the things we can learn also about the diaphragm activity is respiratory metrics. So I think a lot of clinical decisions are based on respiratory rate at the bedside. As of today, the respiratory rate you see on a ventilator is the ventilator respiratory rate. It's not the patient's. So this is a study that was done in preterms. It's Paolo Navalese and his group. And what they did was they did 4 hours of PRVC and 4 hours of NAVA split into different epochs. And they looked at the mechanical respiratory rate, which is the ventilator respiratory rate, and the neural respiratory rate. And you can see clearly the difference between the two on PRVC, whereas during NAVA, there was no difference between the two. So for accurate respiratory metrics, very important to keep in mind that the ventilator rate is not necessarily the patient rate. Here you have a slide. I've summarized all the work that's been done over the years where diaphragm activity has been reported. And you can see here the ranges. This is adults, pediatric, neonatal, intubated, non-invasive, or with no assist. And you can see here the range we're talking is around 10 to 20 microvolts for a mean group. This is a number of patients in each group here. So this is my summary slide, and I'm hoping it can kind of set the stage for the next 2 days' lectures. What can I learn from the diaphragm electrical activity? Well, the first thing is you can actually ask yourself, is my patient breathing? So if your patient is not breathing, you must investigate, because a patient should be breathing. You must investigate if they're over-assisted, over-sedated, or if this is a central apnea issue for babies. If they are breathing spontaneously, are they synchronous with the ventilator? If they're not synchronized with the ventilator, you can optimize using the diaphragm activity, your conventional settings. You can use NAVA. Once you are synchronized, now you have an accurate measurement of neural respiratory rate. You can follow your EDI peak and min values as you give treatment, whether it's PEEP, whether it's bronchodilators. You now have accurate information to work with. And then you can start to target your diaphragm activity. You can minimize your minimum diaphragm activity. You can combine EDI with other parameters, and you can think about using the EDI for weaning. And I think that's it. Yeah, if you have questions. And this is our website where we're filming a lot of these lectures today. And from 2012, we have all our old lectures. So I want you to inhale, exhale, smile, and repeat. Keep breathing.
Thanks very much, Jennifer. That was a great start and I think a great background for this meeting.